Good morning and welcome everyone to the second day of our ACIP meeting. Today is October 26th, and I'm pleased to call our ACIP meeting to order. I will now take roll call for our members only. As a reminder, we are going to ask that you state your conflicts because we do have a vote later today. And I will go in alphabetical order. So we'll start with Ms. Bata.
Good morning, Lynn Bata, Immunization Clinical Consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Bell?
Beth Bell, Clinical Professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Dr. Chen?
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Sineas?
Sybil Sineas, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning, Matt Daly, Senior Investigator, Institute for Health Research, Kaiser Permanente, Colorado. No conflicts of interest. Thank you.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Lair?
Jamie Lair, Private Practice Family Medicine, Ithaca, New York. I have no conflicts.
Thank you. Dr. Long?
Good morning, Sarah Long, a Professor of Pediatrics in Pediatric Infectious Diseases at Drexel University College of Medicine. I have no conflict.
Thank you. Ms. McNally?
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling?
Kathy Paling, Professor of Pediatrics and Epidemiology and Prevention at Atrium Health, Wake Forest School of Medicine. I have no conflicts. Thank you.
Thank you. Dr. Sanchez?
Good morning, Pablo Sanchez. I'm Professor of Pediatrics at The Ohio State University and a neonatologist in pediatric infectious diseases at Nationwide Children's Hospital, and I have no conflict.
Thank you. Dr. Talbot?
Good morning, Kip Talbot, Professor of Medicine and Health Policy at Vanderbilt University Medical Center. Think for a second. Division of Infectious Diseases, no conflict.
Thank you. And this is Grace Lee, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. So next, we will move on to our agency updates. We will begin with the Centers for Disease Control and Prevention.
Good morning. My name is Dimitri Daskalakis, and greetings on day 2 of ACIP. I'm the acting director of the National Center for Immunization and Respiratory Diseases, and again, it's a pleasure to see you for day 2. So I'll start by just talking a little bit about what our primary focus is at this time of year, which is our respiratory virus season. So I think, as you all are aware, and your partnership is so important in this, protecting people against respiratory diseases this fall and winter is really not a top priority for the agency, but also a top priority for the nation. It's important to protect people and important to also protect healthcare so that we have the capacity to treat and care for people who don't have respiratory diseases. It's good news. We are thankfully in our strongest position that we've ever been for fighting these respiratory conditions, COVID-19, respiratory syncytial virus or RSV, and flu. So of course, with such an erudite group, it's really important to note, we know that there's more than 3 that we work with during this season and other seasons, but because there are many exciting interventions that we have for these, we have a lot of focus, as well as the fact that these 3 tend to be the ones that are detectably causing the largest strain on healthcare and burden of disease. So in terms of where where we are today, currently COVID-19 activity continues to decline in most parts of the country. But when you look at the overall story, it remains the principal cause at this time of year of respiratory virus associated hospitalizations and deaths. Influenza activity does also remain relatively low, but not for long. We're seeing activity starting to increase in the country, and right now, some areas, particularly Alaska and the Mariana Islands, are actually seeing a pretty significant increase in influenza. Also, we are officially now in RSV season. We've hit the 3% threshold, and we are seeing the normal progression of RSV in the country starting in the south and slowly making its way up north, with the expectation that we will be in RSV land in the United States the whole way in about 1 to 2 months. A couple of important things to highlight. On October 23rd, CDC published a healthcare provider toolkit preparing your patients for the fall and winter season. This toolkit is great. It provides clinical and other partners talking points. So we're all really on the same page of how to talk to people, other providers, and people that you care for about flu, COVID-19, and RSV, as well as their interventions, including vaccines and treatments. Also, with some focus on co-administration and some print materials that can go to patients so that we can really be on the same page for communicating. So not shockingly, I will tout the importance of vaccines here. The vaccines remain the safest protection to avoid hospitalization, also long-term health impacts and death. It's, again, as you all know, especially important for people who are at higher risk of developing serious complications. That includes older adults and folks who have weakened immune systems. Though it's a campaign that focuses on flu, so much of this does sort of fall into the wild to mild category, that these vaccines are taming these infections, really an effective way of communicating what the role of these vaccines are in people's health, and as well as in public health. So bottom line is that we encourage everyone and really appreciate your help in being frontline warriors in this. We encourage people to stay up to date on their vaccinations. Another really important piece of what's happening this season is that we've had a very significant change in the way COVID-19 vaccine is distributed in the United States. So we have had the experience of the largest U.S. government implemented vaccination program in U.S. history, 700 million doses of COVID-19 vaccination that have been administered to over 270 million people. That's amazing. On September 15th, something changed. A switch was flipped, in effect, where we went from U.S. government distribution of COVID-19 vaccine into distribution through commercial networks. And I think that's been really instructive in terms of some of the very important observations that strategies for public health distribution of vaccine tend to be different than strategies for commercial distribution of vaccine. And I think despite a year plus of planning, definitely some very important lessons learned about how public health can potentially better influence how commercial vaccine moves in the country. So what we also learned is that we don't have a vaccines for adult program. And so as we see COVID-19 vaccine going onto the commercial market, there was a significant concern that we really needed to make sure that uninsured or underinsured people who live here are able to access vaccination, regardless of their insurance status. And so thus was born Bridge, a bridge to somewhere, I hope. CDC launched the COVID-19 Vaccine Bridge Access Program in mid-September. Very accelerated, large program that really created the possibility of access for 25 to 30 million Americans who are uninsured, and then additional people living in the country who are underinsured. The Bridge program leverages unique public-private partnerships with pharmacies as well as with manufacturers of vaccine to really create a two-channel system, one that's a public health channel that really focuses on our vaccine partners that work in health departments and the providers that they have that administer vaccine to their jurisdiction, but then also really great partnerships with the very important channel, the retail pharmacy channel, where we have 3 partners that are participating in really creating a sort of double-headed net to be able to provide people access to vaccine. So I'm going to go back to the story of Bridge and say it's great because it provides COVID-19 vaccination. It's temporary, and it only provides COVID-19 vaccination. And so this is really sort of where I pivot for a moment to say vaccines for adults is a really important strategy. We know that vaccines for children is a game changer. I come from many various infectious disease spaces in my career, and I always step back and think that the two things that you see really having really enormously high impact in terms of public health interventions, Ryan White and the VFC. So these are just so important in the world in terms of being able to provide people the prevention and services that they need to stay healthy. So a bridge to somewhere, I hope it's a bridge to VFA, and so really thinking about strategies that we can create a program in the US that is not a two-legged stool that's a little wobbly, but a three-legged stool that includes the 317 program, VFC, and VFA, so that we can actually create that prevention strategy that works so well, since we know that vaccines prevent a lot of bad things. Speaking of that, time to talk about VFC. VFC is amazing. It is a federally funded mandatory entitlement program that provides vaccines at no cost to children who might not otherwise get them. And so I'm sure you've heard these figures before, but it's always good to remember. Imagine what we could do if we had both VFA and VFC. In its 30-year history, happy anniversary VFC, it has prevented 472 million illnesses, over 1 million deaths, and nearly 2.2 trillion with a T in societal costs. Seems like a really good idea. Every dollar spent saves $10, almost $11 in projected healthcare costs. We know that since 1994, VFC has been critical in increasing rates of vaccine uptake in US kids, reducing vaccine preventable diseases, and as I said, it is an equity intervention that really reaches the most vulnerable people who otherwise may not be able to get vaccine. VFC is important because for lots of reasons, but one of its main purposes is to buy vaccine. 90% of that program funding comes from that. So I get asked frequently, what is the difference between like a VFC, VFA, and 317? 317, about 3% of its budget goes to purchasing vaccine, and it's kind of an emergency safety valve, provides infrastructure that supports VFC and could support VFA. Three legs to the stool are really critical to be able to achieve the goal. Now, I want to talk a bit about something that is really important to be aware of. I think you all are tracking very closely Nirsevimab and what we're seeing with some of the supply constraints. So as you know, we're aware that Nirsevimab, which is a very important long-acting preventative antibody that is to prevent RSV illness in newborns, has some limited supply. And on October 23rd, CDC issued a health alert, or a HON, that advises healthcare providers to prioritize the antibody to those who need it most. So young infants, birth age through 5 months, infants with high-risk conditions, and then also we know that it's really critical to have this reach American, Indian, and Alaska Native infants, given the burden of disease that we see in that population, especially if they're in remote settings. Additionally, in that health alert, we also reminded people of alternatives for some babies and newborns between 8 to 19 months with certain medical conditions, so specifically palumizumab, so that we are able to spare some of the 100 milligram doses, which is where we're seeing some of the issue or most of the issue. So again, we also highlight that there is another way, so a couple paths to protection for newborns for RSV, and that includes vaccination in pregnant persons. I think you all met about that on October 22nd, so you're all on top of it. So again, we continue to be in really close contact with Sanofi to make sure that we have a chart forward for the season. Just remembering again, commercial distribution and supply is different than public health or US government distribution or supply. So it's really lucky that we have a strong partnership to be able to make sure that we are in close communication. I do, however, again, want to uplift one point that we do have Nirsevimab, we have palumizumab, and we also have vaccination in pregnant persons, reminding you that the recommendation immunization is 32 to 36 weeks of pregnancy. So again, vaccines, critically important. It's important to get them to people, both from the manufacturing and distribution side, but also from the access and coverage side. So I think that we are in a place of strength, but also we have some really important areas to continue to address so that we maintain that strength and do it in an equitable way. Thank you.
Thank you very much, Dr. Daskalakis. Next, we will move on to the Centers for Medicare and Medicaid Services.
This is Mary Beth Hansen. I have a few updates from CMS, which will be very consistent with what we just heard from CDC. One thing we wanted to just highlight, although I'm sure many people are aware, is that the Inflation Reduction Act provision that would require that traditional Medicaid cover all ACIP recommended vaccines without cost sharing went into effect on October 1st. These are adults who are in what we call traditional Medicaid, which is the pre-expansion Medicaid. Previously, vaccines were optional for states and there could be cost sharing. We know that all states covered some, but most did not cover all ACIP recommended vaccines. And this is a very exciting day that we're in from the Medicaid perspective and vaccines for adults. Obviously, there's still a lot of work to do in this space, but this is an important step forward. So again, that went into effect on October 1st. We did issue guidance to states as well as a fact sheet at the end of June. Moving on to recent vaccinations and most importantly, coordination with CDC. As you've just heard, there has been a lot of things happening this fall, and we have worked very closely with CDC on all of them. Obviously, the commercialization of COVID vaccines was a very important transition, and CMS was in the middle of it. We worked really hard to amplify messaging, to get information out, to be consistent with what CDC was sharing. And I really appreciate CDC colleagues coming and speaking to Medicaid agencies about the Bridge Access Program and making sure that they were aware of that. We also have worked very closely with CDC around the new products that are available for RSV and amplifying important information about them being available, including the supply issues that we just heard about, and making sure everyone knows of everything that is available in this space. It is also not important that we don't lose sight of our routine immunizations with, everything else that's happening in this space. So we continue to amplify the importance of routine immunizations and have reiterated that message many, many times to states, as we're also making sure that states are aware and other partners are aware of all these important changes happening in this space. So thank you very much.
Thank you very much, Ms. Hance. Next, we'll move to the Food and Drug Administration.
Thank you, Dr. Lee. David Caslow, Office of Vaccines Research and Review, CBER, FDA. Since the last ACIP agency report in June of 2023, and apropos to yesterday and today's ACIP meeting, FDA has approved or authorized 10 vaccine products, issued an updated guidance to industry, and convened one Vaccines and Related Biologics Products Advisory Committee. On June 30th, CBER approved a change to the prescribing information of Dengvaxia, the dengue tetravalent vaccine live, to include safety and efficacy data that support the use of Dengvaxia in individuals 6 years through 16 years of age with a laboratory-confirmed previous dengue infection and living in endemic areas. On July 20th, CBER approved Cyfendus, anthrax vaccine absorbed adjuvanted, indicated for post-exposure prophylaxis of disease following suspected or confirmed exposure to Bacillus anthracis in persons 18 through 65 years of age when administered in conjunction with recommended antibacterial drugs. On July 27th, CBER approved a change to the prescribing information of Ervebo, the Ebola Zaire vaccine live vaccine, to extend the indication for use to individuals 12 months of age and older. On August 21st, CBER approved Abrysvo, the respiratory syncytial virus vaccine indicated for active immunization of pregnant individuals at 32 to 36 weeks gestational age for the prevention of lower respiratory tract disease and severe lower respiratory tract disease caused by respiratory syncytial virus in infants from birth through 6 months of age. On September 11th, CBER approved Comirnaty and Spikevax 2023-2024 formula COVID-19 mRNA vaccines for use in individuals 12 years of age and older, and amended the emergency use authorizations of Moderna COVID-19 vaccine and Pfizer-BioNTech COVID-19 vaccines to include the 2023-2024 formula for use in individuals 6 months through 11 years of age to prevent COVID-19. Then on October 3rd, CBER amended the emergency use authorization of the Novavax COVID-19 vaccine adjuvanted to include the 2023-2024 formula for use in individuals 12 years of age and older to prevent COVID-19. On October 20th, CBER approved Pembraya, meningococcal groups A, B, C, W, and Y vaccine indicated for active immunization to prevent invasive disease caused by Neisseria meningitidis. Serogroups A, B, C, W, and Y. The vaccine is approved for use in individuals 10 through 25 years of age. And on October 19th, CBER issued an updated development and licensure of vaccines to prevent COVID-19, guidance for industry to assist sponsors in the clinical development and licensure of vaccines for the prevention of COVID-19. And then finally, on October the 5th, VRPAC convened an open session to discuss the strain selection for influenza virus vaccines for the 2024 Southern Hemisphere influenza season. The committee unanimously recommended excluding the B. Yamagata lineage component from quadrivalent influenza vaccines as soon as possible, as well as recommended the composition for egg-based trivalent and quadrivalent 2024 Southern Hemisphere formulations of influenza vaccines. And if I might, I'd like to personally thank the review teams, the supervisors, and the management at CBER who worked diligently to thoroughly review these 10 regulatory actions since the June 2023 ACIP meeting. And I'd also like to thank the many CDC staff for their many contributions and their alacrity in these efforts. That concludes the FDA agency report to ACIP.
Thank you very much, Dr. Kaslow. Next, we'll move to Health Resources and Services Administration.
This is Commander Grimes with the Health Resources and Services Administration. A couple of updates for our injury compensation programs. The National Vaccine Injury Compensation Program, or as we call the VICP, continues to process a high volume of claims. In fiscal year 2023, petitioners had filed 1,129 claims with the VICP, and nearly $174 million have been awarded, including awards to petitioners and their attorneys' fees and costs. In addition, the VICP had a backlog of 657 claims alleging vaccine injury that were awaiting review. Previously, there had been nearly a 12-month wait time between when a petition was found to have adequate medical records to review by the time a HRSA provider was able to review it. And as of October 1st, 2023, those wait times have been reduced significantly to below a 6-month wait time. So we are working through the backlog in that VICP program. More data about the VICP can be obtained at the VICP's website, which is hrsa.gov/vaccine tech compensation. For our other injury compensation program, the Countermeasures Injury Compensation Program, in the decade prior to COVID-19, only 500 claims had been filed with the CICP. CICP received its first direct appropriation in fiscal year 2022, and the program has used those funds to increase its capacity to conduct medical reviews by hiring and training new review staff and contractors, as well as to pay compensable claims and to improve information technology and other communication with requesters. The CACP recently made IT improvements to foster enhanced communication with requesters, allowing the requesters the capability of checking their claim status in real time at injurycompensation.hrsa.gov and launching a chat function on its website to assist requesters with frequently asked questions. As of October 1st, 2023, there have been 12,233 claims alleging injuries or death from COVID-19 countermeasures that have been filed with the CICP, including 9,221 claims alleging injuries from COVID-19 vaccines. CICP has rendered 1,267 decisions on COVID-19 claims, and more information, in-depth data about the CICP can be found at www.hrsa.gov/CICP tech data. Over to you.
Thank you very much, Commander Grimes. Next, we'll move on to the Indian Health Services.
Thank you, Dr. Lee. This is Matthew Clark with IHS. The Indian Health Service continues to prioritize vaccination as our principal clinical and public health prevention priority. As part of our IHS National E3 vaccine strategy, we seek to ensure that every patient at every encounter is offered every recommended vaccine when appropriate. In partnership with staff at our Federal Tribal and Urban Indian Organization facilities, we have collected and shared best practices and lessons learned from dozens of E3 Champions pilot sites across the country for cross-pollination of our IHS system of care. We are actively engaged in our fall respiratory viral season vaccine campaign with the goal to mitigate morbidity and mortality from vaccine-preventable illness in our vulnerable service population. Following approval of the 2023-2024 monovalent COVID-19 vaccine and RSV vaccines for elders and pregnant women, the IHS distributed guidance to clinicians, public health staff, tribal leaders, and tribal communities about the importance of these countermeasures. Similarly, coinciding with the ACIP recommendations, the Indian Health Service took quick action to add Nirsevimab to the IHS National Core Formulary to further promote access to this immunization for infants and young children. We have also reached out to our federal, tribal, and urban Indian organization partners to provide guidance about the recommendation that all infants under 8 months of age in their first RSV season and all American Indian and Alaska Native children 8 to 19 months of age in their second RSV season receive Nirsevimab. Currently, all ACIP recommended vaccines and long-acting monoclonal antibodies are listed on the IHS National Core Formulary. In addition, IHS continues as a long-term partner with the Vaccines for Children program, and IHS also remains committed to providing support to facilities interested in the CDC's Bridge Access program for COVID vaccines for eligible persons. Moving forward in collaboration with our partners and tribal communities, we will continue to promote access, quality, value, and equity related to immunizations in Indian country. That concludes the IHS report. Thank you.
Thank you very much, Dr. Clark. Next, we'll move on to the National Institutes of Health.
Yeah, good morning. This is John Beigel from the National Institute of Allergy and Infectious Diseases. I have several updates from the National Institute of Health. For COVID-19, several months ago, the National Institute of Allergy and Infectious Diseases and BARDA, the Biomedical Advanced Research and Development Authority, announced Project NextGen. This is a coordinated effort where the federal government works with private sector to advance pipeline of new and innovative vaccines and therapeutics for COVID-19. Next-gen vaccines include those with an enhanced breadth, improved durability, and those that with the ability to block transmission or infection, including mucosal vaccines. And we're looking for ways to improve upon the currently approved vaccines. And NIAID plans to leverage existing infrastructure and networks to implement these studies, evaluating multiple next-generation COVID-19s. Links to the program will be in the written updates, but you can also find them by internet search. For Mpox, we spoke yesterday about NIAID's immunogenicity trial of the Jynneos Mpox vaccine. This includes an evaluation of a lower intradermal dose and a non-inferiority adolescent safety and immunogenicity trial that both stages have completed enrollment. The data for the initial results for the intradermal stage are expected early 2024, with the adolescent data coming later. For meningitis, researchers from the NIAID-funded Infectious Disease Clinical Research Consortium provided an interim report on the pentavalent meningococcal serogroup ACYWX conjugate vaccine in comparison to the ACWY conjugate vaccine. This was presented to the WHO Strategic Advisory Group of Experts, also known as SAGE. This is different, and just to be clear, this is different than the pentavalent vaccine discussed yesterday, including serogroup X, which is seen in many African countries. The study results show that the pentavalent vaccine is safe, highly immunogenic. And this pentavalent vaccine had already been shown immunogenic and approved, actually, for people's age 1 to 85. But this was the pivotal study that extended that down into the infant age group so that that vaccine can be used as part of routine immunization schedule in low and middle income countries. For HIV, NIAID continues to support multiple programs in pursuit of an HIV vaccine. One recent example to highlight the first in human trial of a HIV vaccine developed by NIAID's Vaccine Research Center, which includes an engineered outer domain germline targeting 60-mer nanoparticle. It's designed to prime VRC01 class HIV-specific B cells. This is a strategy that is priming B cells, and then you refine them with additional antigens in order to develop these broadly neutralizing antibodies. The result of this early phase clinical study was published earlier in Science Translational Medicine, and the links will be in the written comments. For sexually transmitted disease in response to the persistent health challenges of HSV, the NIH released a strategic plan on HSV research. This includes a framework with 4 strategic priorities, including improving fundamental knowledge of HSV biology, pathogenesis, and epidemiology, improving HSV diagnostics, improving strategies to treat HSV while seeking curative therapeutic, and advancing work on preventative measures, including HSV vaccines. So hopefully this will help stimulate and lead to effective HSV vaccines. And lastly, for leadership updates, Dr. Tabak, who is the acting director of the NIH, named Jeannie Marazzo as the director of NIAID. Dr. Marazzo is well known by many people in this group. She's internationally recognized for her research and education efforts in the field of STIs, especially as they affect women's health. And we're very excited to have Dr. Marazzo leading NIAID as we continue efforts for new and better vaccines. So details and links for all of these, as well as additional updates, will be provided in the written summary. This concludes the updates from the National Institute of Health.
Thank you very much, Dr. Weigel. Next, we'll move on to the Office of Infectious Disease and HIV/AIDS Policy.
This is Susan Farrell from the National Vaccine Program in HHS's Office of Infectious.
So sorry, we can't hear you very well. Could you get closer to the mic? Thank you.
Better now?
It's a little better.
Hi, this is Susan Farrell from the National Vaccine Program in the Office of Infectious Disease and HIV/AIDS Policy. Our report today is that federal agencies comprising the Interagency Vaccine Working Group have provided feedback to inform the vaccine's Federal Implementation Progress Report, expected in December 2023. The progress report will give an overview of progress from 2021 to 2023 towards achieving the goals of the vaccine's National Strategic Plan, which provides a roadmap for the coordination of vaccine development and use in the United States. The Office of the Assistant Secretary for Planning and Evaluation, that is ASPE, and our office, OIDP, have jointly released an environmental scan report titled Environmental Scan of Best Practices for COVID Vaccination and Testing for Underserved Populations. This document provides a comprehensive literature review and describes initiatives and interventions to improve COVID vaccination for people who are medically or socially at disproportionate risk of COVID-19. This report can be found on the ACIP website. Finally, the forthcoming National Vaccine Advisory Committee meeting is scheduled for February 22nd and 23rd, 2024. Thank you. That concludes our report.
Thank you very much for that report. Dr. Daskalakis?
Thank you so much. I want to apologize for not introducing our colleagues from Sanofi who also would like to make a comment on the supply of Nirsevimab. So Dr. Chen, thank you for allowing me to grab the mic again to introduce them. Thank you.
Thank you, Dr. Daskalakis. Good morning. I'm Julian Ritchie, Head of Public Affairs and Patient Advocacy for Sanofi Vaccines. On behalf of Sanofi Vaccines and our alliance partner, AstraZeneca, I appreciate the opportunity that NCIRD is providing for us to comment on the current market situation for Beyfortus or Nirsevimab. As Dr. Daskalakis shared, we're experiencing unprecedented demand for Beyfortus in response to the unmet need that has existed in RSV prevention. Despite an aggressive supply plan built with the goal of outperforming past pediatric immunization launches and built to anticipate the demand of this season, the demand that has materialized has been much higher than forecasted across both the 50 milligram and 100 milligram presentations. Both product dose presentations do continue to ship to fulfill existing orders. However, for the 100 milligram presentation, we have stopped accepting new orders as demand has consumed the supply currently available for this season. We will continue shipping doses of the 100 milligram to fulfill orders already on hand over the coming weeks. Orders are still being accepted for the 50 milligram presentation. We're working closely in collaboration with the Centers for Disease Control and Prevention to ensure equitable distribution of available doses through the VFC program. Our approach for fulfilling existing orders and in taking new orders for the 50 milligram product across the private marketplace will also be done in a similar manner with equity in mind. We appreciate the clinical guidance provided by CDC earlier this week via the HAN that was mentioned before. Additionally, we're working with the FDA together with AstraZeneca, our partner in charge of the manufacturing and supply, to deliver all of the doses planned for this season. We appreciate the challenge that these supply constraints present for providers and parents, as well as for CDC, the FDA, and AAP, and others, as we introduce Beyfortus. We are thankful for your patience and your collaboration. We're already working to ensure there will be sufficient supply available for next season as we continue to focus on making this season's doses available as rapidly as possible. We will continue to update you and providers on the status of orders and remaining shipments. For any questions about the status of Beyfortus orders currently placed directly with Sanofi, providers can reach out to their local Sanofi representative or call 1-855-Beyfortus regarding private sector doses. For public sector doses, providers can reach out to their state and local VFC program. Again, thank you for this opportunity to comment. Sanofi and AstraZeneca appreciate the patience of the immunization community as we work together through this introductory season and as we prepare to meet demand in the future. Back to you, Dr. Daskalakis.
I'll hand it back over to Dr. Chen.
It's okay. Actually, Dr. Cotton and Dr. Long. So Dr. Cotton, I see your hands is raised.
Thank you. I just have one question for Dr. Daskalakis. If you could address RSV vaccine availability for pregnant people and how that's going. Thank you.
Thanks, Dr. Cotton. So just briefly, I think we will have sort of a better view of what's happening in terms of coverage as we go further in the season. But in general, I'll say that because this is a commercially distributed vaccine, we've been really in close contact with manufacturers and distributors to have a sense of sort of what's happening on the ground, as well as really close discussions with our shareholders around the country, including professional organizations, et cetera. So I'll start by saying there does not appear to be a bottleneck in production of the vaccine. So from the perspective of what we've heard from manufacturers as well as from distributors, vaccine is flowing. What we are hearing is that there are some barriers related to concerns around coverage. So CDC is actively engaging across, again, shareholders that deal with coverage, both governmental, CMS, and also others, to make sure that the message is clear, the importance of this vaccine product for pregnant people and for their newborns. Additionally, many engagements have happened and more are planned to be able to sort of tout the importance of the vaccine and also to do some myth busting around sort of what is available as well as what we sort of forecast will be the coverage scenarios. There will be some coverage issues because there are some limits to the speed at which a private insurer needs to cover this, but we're engaging with them as well to, again, highlight the importance of a public health view into strategies that tend to be more on the commercial side of the fence. Thank you.
Thank you. Dr. Long?
Yes, it's a question for Dr. Ritchie, Sanofi. So we should be winding down on need for the 100 milligram vials as we catch people who are a little older at the beginning of the season in the next month. But the 50s we'll need through March, and they are the most vulnerable. Do you, at what level of uptake did you plan for? And what do you anticipate as far as potential shortages of the 50s?
Thank you, Dr. Long. And as far as the 50s, I don't have specific numbers to share in terms of volume, but it's something we're watching very closely. At this point, seeing the level of ordering that happened early on, we're still trying to understand how much of that ordering is early in stocking ordering and the utilization that will go forward. So the CDC can speak to more of the specifics of the VFC program details, but for non-VFC and private sector doses, we're monitoring that 50 milligram order very closely, and we'll work to adjust any order quantities going forward if we detect that.
Thank you. Dr. Sanchez?
Thank you. And this is also a question for Sanofi. I just had a question in terms, I know that the 100 milligram supply is limited, and I certainly don't want to give 250 milligram to those who would normally get 100. But my question is the experience in what's the content of the 50 milligram, is that if you give 2 of them, are you giving too much of the whatever else is contained in that product? Do you understand my question?
I do, Dr. Sanchez. Thank you for the question, and I'll engage my colleague, Dr. Rizzo, also on the line here. At this point, of course, I just want to note that use of the 250s is outside of indication, and I think consistent with the HAN, not recommended at this point, given the fact that that's consuming 2 doses that would be used in otherwise young individuals, and considering that there are other options, presumably for the individuals for whom you would use the 100 milligram formulation. But let me ask Dr. Rizzo to also comment.
Yeah, hi, it's Chris Rizzo from U.S. Medical Affairs at Sanofi. Dr. Sanchez, to your question, the excipients that are in it include arginine, histidine, polysorbate, and sucrose. So I don't know if we have any data on that, but just for the 100 milligrams, a baby is getting double that. So once they cross 5 kilos, they're getting double that amount. But I don't have any specific data on that. But I will also support what Julian said, is that in the HAN, it's not recommended to give 250s because of concerns potentially about the 50 milligram, and we could give it to 2 babies who are younger. rather than one baby who's older, but I know that there are older babies who are at very high risk as well.
Okay, thank you. We're going to close this part of the session. I did just on behalf of our committee want to express our appreciation for the agency leadership who spoke today at our meeting to provide these updates. It is really clear and it demonstrates how cross-agency partnership and collaboration can actually have such a tremendous impact on the health of the U.S. population. And so I know all of us are extremely grateful that you are willing to serve and appreciate all that you do. So thank you, everyone. We will move on to the next session, which is on combined immunization schedules. And Dr. Sybil Sineas, who is chair of the Adult and Child Adolescent Immunization Schedule Work Group, will be walking us through the introduction and overview for today.
Thank you, Dr. Lee, and good morning. Next slide. The Combined Immunization Schedule Work Group updates the child and adolescent and adult immunization schedules annually. The child and adolescent immunization schedule summarizes ACIP's vaccination recommendations for persons 18 years of age or younger, and the adult immunization schedule summarizes ACIP's vaccination recommendations for persons 19 years of age or older. Both immunization schedules represent current approved ACIP policy and are designed to be a guide for healthcare providers to ensure individuals get all their vaccines when they need them. Next slide. The goal of the Combined Immunization Schedule Work Group is to better harmonize the child-adolescent schedule and the adult schedules. No new policy is established by the schedule. Rather, it reflects a summary of ACIP recommendations. Next slide. I would like to remind the committee and the audience why we present the schedule for a vote every fall. ACIP's approval is necessary prior to publication of the immunization schedules by CDC. In addition, ACIP's approval is necessary before our partners from the professional organizations listed on this slide approve the schedules. Next slide. This slide depicts the traditional timeline we have used to publish the immunization schedules, the accompanying MMWR article, and the adult schedule in the Annals of Internal Medicine. All publications occur on the same day in early February each year. Next slide. The traditional timeline and process of updating the schedules has resulted in a few significant challenges in implementation of routine vaccinations. This includes insurance reimbursements to healthcare providers, the ability of certain healthcare providers, such as pharmacists, to administer vaccines in some jurisdictions, and delays in updating healthcare providers' knowledge and practices related to new vaccine recommendations. Next slide. To mitigate some of these challenges, we are proposing publishing the 2024 immunization schedules, web, PDF, and app versions in November 2023. The MMWR article summarizing the updates to the 2024 schedule will then be published a few months later, but earlier than the current February dates. Next slide. I would like to acknowledge the exceptional leadership of our CDC co-leads, Dr. Patricia Woody and Dr. Neil Murthy. In light of many additions and edits to the schedules this year, I would also like to acknowledge the contributions of my ACIP colleagues, Veronica McNally and Dr. Matthew Daly, and thank the many liaison representatives, ex officio members, consultants, and CDC subject matters listed here and on the next slide, who have contributed to the work group activities. Next slide. As a reminder, presentations on updates to both schedules may include the use of vaccine trade names. This is for identification purposes only and does not imply endorsement by CDC. The proposed edits that will be discussed are subject to change based on ACIP's discussion and vote. Next slide. For today's presentation, Dr. Woody will discuss the proposed edits for the 2024 child and adolescent schedule, as well as the proposed edits for the 2024 adult immunization schedule. These edits are intended to incorporate ACIP recommendations that have occurred since October of 2022, improve readability and utility of the schedule into language that is easy to interpret for practitioners. The session will conclude with discussion of the proposed edits, followed by a vote on the adult schedule and the child and adolescent schedule. I will now ask Dr. Woody to begin our session with the proposed edits to the child and adolescent schedule. Thank you.
Thank you, Dr. Seniors. Let me just share my slide. I'm just pulling up my slide. Wait a minute. Good morning, everyone. My name is Dr. Woody, and together with Dr. Omothi, we co-lead the Combined Immunization Schedule Work Group. I will begin by presenting the 2024 updates to the child and adolescent schedule. I will walk through the proposed changes for the cover page and the tables, then the vaccination notes, and then the appendix, and then introduce the newly added addendum. The 2024 updates include new and updated recommendations for vaccines in red text. Additionally, we've made clarifying edits to the other vaccines listed on the slide. I will present only the substantive updates to the schedule. Minor grammatical or formatting edits to improve clarity will not be presented. I'll begin with the cover page of the child and adolescent schedule. In the box for how to use the schedule, we've added a 6-step for providers to review the addendum for ACIP recommendations that will occur after the schedule is published. The title for the table listing the names and abbreviation has been changed to vaccines and other immunizing agents because we've added Nirsevimab to the table. Nirsevimab has been added in a separate section at the top to indicate that it's a monoclonal antibody and not a vaccine. In the table listing the vaccine names and abbreviations, we have a new role for RSV vaccine, and we've listed only the brand Abrevcio because this is the only brand approved for use in pregnancy. In the pneumococcal conjugate vaccine role, we've deleted PCV13 and added PCV20 to be consistent with the current guidelines. And then we've added new roles for Mpox vaccine Jynneos and the pentavalent meningococcal vaccine. Lastly, on the cover page, we've deleted some vaccines that are no longer distributed or recommended for use in the United States. So we've deleted the bivalent mRNA vaccine. The diphtheria tetanus vaccine is no longer available, so that row has been deleted. And then from the meningococcal ACWY row, we've deleted Menacra. Moving on to Table 1, which outlines the immunization schedule by age. In Table 1, the column header has also been changed to vaccine and other immunizing agents to account for adding Nirsevimab to the table. We have a new role for Nirsevimab, and we've shaded the ages birth through 8 months in yellow, indicating the age for routine immunization. We also have an overlaying text saying the one dose depending on maternal RSV vaccination status. And then for ages 8 through 19 months, we've shaded that in purple to indicate that it's for those 8 through 19 months who are at increased risk of severe RSV disease. And we've added C notes to direct healthcare providers to the notes section for more information for these 2 age groups. We've added RSV vaccine to Table 1, and we've shaded age 11 years to 18 years in purple, and we have an overlaying text, seasonal administration during pregnancy, and to C notes. In the pneumococcal conjugate role, again, we've taken out PCV13 and added PCV20. And the pneumococcal polysaccharide role has been deleted because that vaccine is no longer recommended for all children who had increased risk for invasive pneumococcal disease. In the meningococcal role, we've removed menacro. And in the COVID-19 role, we've removed the mRNA bivalent vaccine, and we've changed the overlaying text to indicate to use the 2023-24 formula. And lastly, to Table 1, we've added a new role for Mpox vaccine, and we've shaded 18 in purple, indicated it should be used based on risk factors. Moving on to Table 2, which outlines the catch-up schedule for children and adolescents who are beginning their immunization late or are more than 1 month behind. We have 2 minor edits for Table 2. In the DTaP role, for those 4 to 5, we've clarified the interval to put a note stating that the 5th dose is not necessary if the 4th dose was administered at age 4 years or older and at least 6 months after dose 3. And the other change is to remove menacro from the meningococcal ACWY role. Our Table 3 lists the immunization schedule by medical indication. This year, we've extensively revised Table 3 to more closely align with the instructions, which is that it's to be used to assess additional vaccines that will be needed based on medical condition or indications. And the reason we did this was because we've received feedback from lots of healthcare providers that the legend definitions were unclear and they were used inconsistently across the role. When we went, the work group changed the color definitions and we harmonized this with the child schedule and applied it to all the roles. So for this 2024 Table 3 looks a lot different. These are the new legend color definitions. We've clarified that yellow is represents recommended for all age-eligible children who lack documentation of a complete vaccination series. Previously, it just said vaccinate according to the routine schedule, so we've explained what that means. And then for purple, we've indicated that it's not recommended for all children, but that some children can receive the vaccine based on their increased risk for or severe outcomes from disease. The definition for brown did not change. It indicates additional doses are needed, but we changed the color from checked yellow to brown so that the overlaying text is more visible. And then lastly, for gray, we changed no recommendation, not applicable, to no guidance or not applicable. We've also changed the table header. We've revised it for clarity. So we say always use this table, always use the table in conjunction with Table 1 and the notes section. And we indicate that there are some medical conditions not listed on this table and to see notes section. Similar to Table 1, we've changed the header to vaccine and other immunizing agents. We've merged the DTaP and TDAP roles into one role, and in the pregnancy column, we've indicated that 1 dose of TDAP is recommended for each pregnancy. We've also merged the pneumococcal roles into a single role, and indicated with the brown color that additional doses are needed for those medical conditions. For Nirsevimab, we've added it as a new role, and then for those children and adolescents who are immunocompromised or have chronic lung disease, we've used the brown color to indicate that additional doses are needed, and an overlaying test to say this is in the second RSV season, and an instruction to see the notes. For RSV vaccine, the pregnancy column is in yellow, indicating it's recommended for all pregnant women. And then we have the overlaying text, seasonal administration. For all the other medical conditions, we have this in purple because any pregnant person who has any of these medical conditions can also receive the vaccine. we have a new rule for Mpox vaccine, and all the medical conditions are shaded in purple, indicating that anyone who has this medical condition and has the sexual risk factors should be vaccinated. Now I'll go over the edits to the notes. In the additional information section, in the bullet for the National Vaccine Injury Compensation Program, we've added RSV vaccine as one of the vaccines that's not covered by VICP. The COVID-19 vaccination notes have been extensively revised to be in line with the current recommendation. The routine vaccination section lists the recommendations for persons who are not moderately or severely immunocompromised, and we've outlined the recommendations by age group and the number of previous COVID-19 doses received. The special situations section outlines the recommendations for persons who are moderately or severely immunocompromised, and we've also outlined the recommendations by age group and number of previous doses received. At the end of the COVID-19 notes, we've included some information that we think will be helpful for healthcare providers, including that there is no preferential recommendation when more than one recommended age-appropriate vaccine is available. We included links to the age transition information, the interim guidance, EUA. We've also added the definition for previously vaccinated. And then lastly, we have a note for additional doses in persons who are moderately or severely immunocompromised. Moving on to HPV, we've made some minor edits here. We deleted the bullet on interrupted HPV schedule because this information is on the cover page and it applies to all vaccines. For situations where no additional doses are recommended, we've clarified that persons who have completed their HPV series with any HPV vaccine do not need additional doses, and we did that by adding of any valency to the sentence. Now for influenza vaccination, we've taken out all the bullets for persons who have a history of egg allergy. And at the end of the section, we've included a note saying that persons with egg allergy can receive any influenza vaccine, egg-based or non-egg-based, appropriate for age and health status. And then we've included the link to the current recommendation for the 2023-24 season. In the MMR vaccination notes, we have moved the bullet for the minimum interval between MMR doses to the end of the section, and we've used asterisks to indicate that it applies to routine, catch-up, and special situations. Previously, it was in the catch-up vaccination section, and some healthcare providers found that confusing. For main ACWY, we've deleted Menatra from all the sections, and we've added the pentavalent meningococcal vaccine. At the end of that section, we have some information for the newly recommended pentavalent vaccine, and that children aged 10 years or older may receive a single dose of the pentavalent vaccine as an alternative to separate administration of men ACWY and men B, when both vaccines will be given on the same day and a single injection with the pentavalent vaccine is preferred. In the Men B notes, we've added a link to the shared clinical decision making, to a shared clinical decision making resource. And at the end of the note, we also have information for the use of the pentavalent meningococcal vaccine. Here we have a lot more information than in the main ACWY note. So children aged 10 years or older may receive a dose of the pentavalent vaccine as an alternative to separate administration of men ACWY and men B, when both vaccines will be given on the same clinic day and a single injection with the pentavalent vaccine is preferred. For age-eligible children who are not at increased risk, if the pentavalent vaccine is used for dose 1, men B dose 1, then Trumemba should be administered for dose 2. And that's because men B vaccines are not interchangeable. And then for children and for age-eligible children who are at increased risk of meningococcal disease, those who need additional men A, CWY, and men B doses, including for booster doses, can use the pentavalent vaccine if both vaccines will be given on the same day and at least 6 months has elapsed since the most recent pentavalent dose. And then lastly, we clarify that for those age-eligible children recommended to receive booster doses of men ACWY and men B less than 6 months after the dose of a pentavalent vaccine, they should get their doses separately. Wait a minute. We have a new section for Mpox vaccine, and we've listed the recommendations for persons aged 18 years and at risk for Mpox with the sexual risk factors listed. We have a bullet for pregnancy stating there is currently no ACIP recommendation for juniors using pregnancy due to lack of safety data in pregnant persons, but pregnant persons with any risk factor described above may receive juniors. For pneumococcal vaccination, again, we've taken out PCV13 and added PCV20. We've added a note stating that either PCV15 or PCV20 can be used where the PCV vaccine is indicated. PCV20 is not indicated for children who have received 4 doses of PCV13 or PCV15 or another age-appropriate complete PCV series. Where we have listed the non-immunocompromising conditions that increase the risk for invasive pneumococcal disease, we've added chronic kidney disease, excluding maintenance dialysis and nephrotic syndrome, because these are listed in as immunocompromising in the immunocompromising section. We've added back chronic liver disease. And for chronic lung disease, we've specified that this includes moderate persistent or severe persistent asthma. And the recommendations are outlined by age group, and for each age group, we've outlined the recommendations based on their previous pneumococcal vaccination history. For poliovirus, in the catch-up vaccination, based on the new recommendation, we've added language for those who are age 18 years, known or suspected to be unvaccinated or incompletely vaccinated. We've also clarified that unless there are specific reasons to believe they were not vaccinated, most persons aged 18 years or born or older who were born and raised in the United States can be assumed that they were vaccinated against polio as children. And then in the special situations section, we've outlined the recommendation for those who have completed their primary series but at increased risk of exposure to poliovirus. And at the bottom, we have a note that defines what a complete primary series means. For RSV immunization with Nirsevimab, we have a new note section, and in the routine immunization section, we have 2 bullets. One outlines the recommendations for infants born October through March in most of the continental United States, and the other for infants born April through September. And in each of these bullets, we've outlined the recommendation based on maternal RSV vaccination history. In the special situations section, we've outlined the recommendations for children ages 8 months through 19 months who are at increased risk for severe RSV disease. In that section, we also have a bullet for age-eligible children who are undergoing cardiac surgery with cardiopulmonary bypass who need additional dose of Nirsevimab, and we have the link to where more information is available. And then at the end of the section, we've added some information on the timing of Nirsevimab administration based on local RSV seasonality, and information on the use of Nirsevimab in children who are eligible to receive palivizumab. And we also added a resources, which is a link to the Nirsevimab frequently asked questions webpage. For RSV vaccine, we've outlined the routine recommendation for pregnant women at age 32 through 36 weeks gestation from September through January in most of the United States. We've also indicated that either maternal RSV vaccination or infant immunization with Nirsevimab is recommended to prevent RSV disease in the infant. And then, just like in the Nirsevimab section, we have information on the timing of RSV vaccine based on local RSV seasonality. In the notes for Tdap, we've made some mild edits, mainly to clarify that 11 to 12-year Tdap dose is the adolescent booster. Now I'll go over the appendix, which lists the contraindications and precautions for each vaccine listed in the schedule. At the header, we've added the link to where you can find the contraindications and precautions for COVID-19 vaccine, the most recent influenza recommendations for 2023-24, and also for juniors vaccination. We've also changed the header to vaccines and other immunizing agents. This year, the contraindications and precautions for COVID-19 vaccines have been incorporated into the table. We have one row for mRNA COVID-19 vaccines and a separate row for the protein subunit vaccine. We've also added Nirsevimab and RSV vaccine to the table. And in the footnotes, we've included a link to the package insert for Nirsevimab. We've also added a pentavalent meningococcal vaccine to the table, listing the contraindications and precautions, and Mpox vaccine juniors. Lastly, we've deleted some information from this table. In the DTaP row, we've removed the diphtheria tetanus vaccine because that's no longer distributed in the United States. And in the Haemophilus influenza row, we've removed the bullet for a severe allergy to dry natural latex because that's no longer included in the package insert. And in the meningococcal row, we've removed the information for Menacra. Lastly, I would go over the addendum. It's currently blank, and what we intend to do is after this schedule is published, any ACIP vote or recommendation will be listed in the addendum. Thank you, and I'll now take any questions.
Thank you. This presentation is now open for questions. And Dr. Paling?
So thank you, Dr. Waddy and Murphy and the entire team. You've taken enormous amounts of data and modifications and really put it in a very coherent and understandable way. So thank you to the entire team. I've got 3 questions that you're probably 3 steps ahead of me. The first one is polio. Did we include the recommendation for 18 and older for those who are unvaccinated?
Yes, and I'll just go back to the slide. Yes. Give me 1 second. Yeah. So in the catch-up vaccination section, we've included a bullet for those who are suspected to be unvaccinated or incompletely vaccinated.
Perfect. Thank you. I knew you were ahead. The second one is on slide 51 about the pentavalent meningococcal vaccine. And it's about the wording.
Oh, sorry.
Okay, no problem. Oh, maybe I've got the wrong number. I apologize.
This one?
If you go back to the previous one. Wait, yes, this one. I'm wondering about the wording, because at the end, we talk about how you can have, when both of them are going to be administered on the same day, and a single injection with Penector is preferred. It kind of sounds like we prefer that, and we did not make a preferential recommendation. And so I worried that this would be misinterpreted.
Yeah, we went back and forth with if indicated. Well, we wanted to communicate that if the patient or the provider had a preference, but we weren't sure how to word that.
I think that it's okay because you said that they may receive a single dose as an alternative to separate administrations when both would be given in the same day, and I would add a period. Because I think that clearly communicates that both are equally reasonable options.
Okay, you can do that.
Okay. And yay, all right. And then PCV 15 and 20.
PCV, so.
Okay. No, this is going to be okay. All right, stop.
Okay.
Back up.
Back up?
The routine. All right, so what I do appreciate the routine and special, but what I'm worried about is that people will look at the routine and not realize, because we've changed the recommendations for the special. And so I like this sentence, but it kind of says that if you've received the complete 4-dose series, you're done, unless you have a condition listed in special situations. And I'm thinking you want to add that so people look at the next page. And that is the end of my suggestions. And only 3 is really good.
Excellent. Thank you, Dr. Paling. Ms. Bata.
Dr. Palin, you always beat me to the hand raising. I also had similar concerns about the language of preferred and actually went to the thesaurus and looked up desired or chosen, but I don't even think it's an important part of the sentence. It doesn't need to be said. And then I know that we do not make policy with the schedule, but I wanted to raise an issue that seems to be kind of bubbling up related to HPV and giving HPV in a more routine recommendation starting at 9 rather than, well, it can be given as early as 9. So that's just put it on in the parking lot for an HPV work group.
Okay.
The question is, there's data growing data that shows better completion of HPV when you start the series at age 9. It kind of removes some of the sexual implications, and it's easier to talk about cancer prevention. But I know that the data is conflicting to some degree, but I just am hoping that the work group could look at that more closely.
So I know that there is interest in reconvening the HPV work group to address, I believe, this issue as well as probably some others. Given the large number of work groups the committee has currently had to support, we've been delayed on getting that started, but hopefully we'll be able to do that soon.
Thank you. Is there anything else, Ms. Bata?
No, thank you.
Thank you. Dr. Cotton?
Thank you. I just wanted to go, I think it's slide 40, which is table 3. And I am not a pediatrician, but I wanted to, well, okay, I'll take that one. Okay, so it's for the RSV vaccine. So, right, perfect. So obviously this is for pregnant children and adolescents, right? But the fact that it's in purple for all those other indications, I know that you mean pregnant people with those indications. But when I look at this, I see purple. So if somebody has chronic heart, lung, or whatever disease, they could consider getting this vaccine even if they're not pregnant. So I would actually make that a different, I would not keep that purple. I think that means that you should be giving RSV vaccine to a lot of people for whom it's definitely not approved. Does that make sense?
Makes sense.
So I think the purple is erroneous.
This has been a recurrent issue with Table 3 and whether to limit the information for each column to only the vaccine that is recommended, or if to also communicate that people with those conditions should receive other vaccines based on routine recommendation or their risk. And so to try to address that problem, the work group leans towards communicating to providers that people who have this medical conditions should also get their routine vaccines. And so when we revised the column, the colored legend, we wanted to leave yellow for those that are routinely recommended for everyone who has that condition. And then purple for those is recommended based on their increased risk for infection or severe outcomes. We struggle with maternal RSV vaccine because it doesn't really fit into any of those colors because we're not giving it to the mother to prevent RSV disease. It's for the infants. None of the other colors fit.
So I would advocate for turning the purple to gray because there's no guidance or not applicable and just keeping it yellow for pregnant people because we actually haven't made this a risk-based vaccine for pregnant people. So all of the other groups here, and I say this out of love because this indication schedule is my absolute favorite thing ever, and I include it in virtually every talk I give because these are the people that I take care of. So I would just advocate for flipping that purple to gray to make it obvious to everybody that this is not recommended outside of pregnancy. For children, yes. Sorry, we're only talking about children. Children and adolescents. Pregnant children and adolescents. Thank you.
Thank you. Dr. Kimberlin.
David Kimberlin, AAP Red Book. Question for you about the new final page that you presented, the addendum page, which of course is empty right now because everything's included in what you just presented. But let's say a new vaccine is approved and ACIP recommends use between now and October, latter part of October 2024. It will be listed on the addendum page, correct? And will it also result in a change to one of the tables in that hypothetical? Or will it only be listed here and the change to the tables will go through the standard process that has been done, ad infinitum, and that you just went through today for the current year?
Yeah. If a new recommendation comes out after the schedule is published, say let's say in February or March, it will be listed on this page. We're currently working on a transition to have a more responsive schedule, and we're hoping to have that plan finalized in the next few months. So at this time, our plan is to list any new recommendations that occur after the schedule is published on this page and not change the other tables until we come up with a new process for having a responsive schedule.
Thank you. I personally would support that. I think otherwise it becomes a real beast to constantly be trying to redo everything. And as long as it's listed here, that, in my judgment, should be enough. Thank you.
Thank you. Dr. Deshawn?
Hi, I'm Dana Deshawn from NAPNAP. Thank you for your presentation. The many new changes on the schedule this year, a lot of work. Any thought of adding page numbers? It's just a practical, helpful suggestion. I just know I have dropped the pages and it's very cumbersome to put them back in order. And my other question is also any thought about alphabetizing the vaccines on the tables and the catch-up schedules like they do on the notes in the appendix just for ease of use? Thank you.
Thank you for your comment. I will see if we can add page numbers. Regarding listing the schedule in alphabetical order, in table 1, and they're actually listed according to when they will be given. So hepatitis B comes first because it's the first, it's given at birth. And that's why we have that order. So the vaccines for younger kids are listed earlier, and then those that begin in adolescents are listed later.
Thank you. Dr. Daly?
Yeah, thanks so much. So I have a question about how the schedule is used, and I would like to propose that we need a research agenda, some modest research agenda, but to know this is a tremendous amount of information that we're trying to convey. It's getting more and more detailed. We're going to run into the situation where we can't fit the schedule on one page. I happen to be color challenged, and I use and this is a visual representation of a ton of information, and I use the schedule a little bit less than I did 20 years ago if I have somebody, for myself, if I'm looking something up or if I'm in clinic with a student, I use it a little bit less. And I'll make two other quick points. One is that we often are operating in a circumstance where there's an electronic health record. Some of these are amenable to electronic health record prompts, and some of these aren't, naturally, something like special situations. And I say this with all the love that Dr. Cotton expressed about the schedule, about the visual representation of the schedule here, but the second point is that I'm often looking up a specific vaccine because there's some detail that I need there. But here, you have to go from one table to the notes to then get the additional information you're seeking versus some other strategy where you're able to find a vaccine with those recommendations very quickly, could be app-based, and should be factored in whether you're operating in an EHR environment or not. That, to me, suggests we need research on how best to convey this information to frontline providers. Thanks.
I'm going to ask for the next few comments if we can be concise, and if there's a response, if you can be concise on the response. Dr. Long.
Yes, if you go to slide 35, again, we're not making policy, but I don't believe there's a varicella work group currently, is there? We're doing well with varicella. So here is the question. You have listed as red.
Is it the varicella notes?
Maybe it's different. It's with the red and yellow and green. It's slide 35 on my handout, but it must not be slide 35 anymore. It's immunization table 3, immunization by medical indication.
Okay.
With the red and yellow and purple and
this
gray.
one?
Okay, there it is. That'll do. So it says here for MMR and V with an asterisk, contraindicated during pregnancy, and then it says, I can hardly read it, it says vaccinate after pregnancy, I think is the word, if indicated. So I have recently seen 2 children in the first month of life who I recognized as very mild varicella, who I then asked the question of the mother, tell me about where you've been. And these were immigrant families. The mother delivered, the mother is from South America, one Central America, one South America. Didn't have varicella as a child, undoubtedly. Baby has no antibody. Mother gets a vaccine in the postpartum period day that she delivers and goes home, and she got a few lesions. The baby got skin disseminated varicella, both of them, not severely ill, but led to spinal tap treatment with acyclovir, thinking it was herpes, and happily I was there. None of the other people in the whole place had seen varicella to know that's what that looked like. So I just don't think the postpartum time, I'm sure it's a public health measure, gets people vaccinated, but it's not a good time for this vaccine, which is a little bit skin transmissible if the mother gets lesions. And maybe mothers from South America who never had varicella are more likely to get lesions than all the people we give it to in the United States who had varicella. However, as I thought about it, we're getting to the point where we're having babies born with only maternal vaccine protection, and I don't know, if that will be adequate for this kind of a transmission. So I just wondered, I bet you struggled with not saying in the postpartum period, but you say after pregnancy, and I suspect that some people are translating this to postpartum, and so I think some group ought to look at that and see if that's still the right thing to do. I would be fine. The first month of life, baby is not immunologically normal, and although we know varicella is very bad in the first 2 weeks, it's probably not perfect if you get it in this 3rd week or the 4th week. And then the other thing that I think is a public health measure too that isn't on these things is what you do for people when they come to the border. You give them a lot of vaccines. There was just a child presented at our ID week who was 15, 16 months old who got MMRNV and 10 days later had the diagnosis of a severe malignancy. Now, did somebody miss that this child didn't look healthy 10 days before? But ended up with enormously complicated course and terrible varicella pneumonia and then measles, both vaccine virus pneumonia. So I don't know what to do about that. It's still a good idea to vaccinate people, but maybe it is just education for people to ask the questions about nobody thought did about this until
Dr. Long?
it was proven.
Sorry to ask, but do you have a specific recommendation for the notes for the section, or are you asking if this could be revisited sort of generally?
Yes, I would like them to think about the note on this pregnancy, after pregnancy.
And how would it be different, just so for clarification?
What did she say?
How would you clarify? What do you recommend?
Probably not in the first days postpartum. I think I don't think you should change this schedule, but I don't want to see it again next year with the same question without someone modeling, what would it do if you didn't immunize all those people compared with immunizing them all on the first postpartum day.
Dr. Wharton, would it be okay if we tabled that question and asked the SMEs for varicella to perhaps work offline with Dr. Long just to make sure we are not changing the recommendation, but it's consistent? I'm actually going to ask, sorry, I'm going to move on. The next few, I'm just going to ask if you can quickly state what you would suggest for the schedule. That would be extremely helpful. And then Dr. Wody at the end will just ask if you have any comments about all of the comments. Commander Grimes.
Yes, thank you. And really appreciate all the excellent work done on this. Can you go to slide 33? Just want to make a quick note here. With the inclusion of Mpox being added to the child and adolescent immunization schedule, Mpox is a vaccine, Jynneos is a vaccine that is covered under the Countermeasures Injury Compensation Program. So this section will just need to be tweaked to recognize that. Thank you.
Thank you. Dr. Paling?
Okay, two things. One, as I was thinking about Dr. Long's question, one option is to remove the asterisks from the red, and that would make it maybe clear. Just a consideration for the work group that's going to discuss it. And then the second was to highlight under the pentavalent, there were 2 paragraphs side by side that had the same as preferred wording, and just making sure we remove that on both. I'm done. Thank you.
Yeah. Ms. Hayes?
Yes, Carol Hayes with ACNM. Dr. Long, I just wanted to point out that the vast majority of women that have not been vaccinated are immigrants, and they are covered during their hospitalization for the birth by Medicaid, but once they leave the hospital, they are uninsured, and they are lost to follow-up many times, and they are lost to care. And so it's one of the reasons why we have always recommended, as long as I've been a midwife, we have always recommended that they are vaccinated immediately postpartum.
Thank you. And then I just have, while we're on this table, I just have one quick comment, which is looking at the RSV Nirsevimab line, you'll see that the second RSV season, it has heart disease or chronic lung disease. I guarantee the question will come up about whether or not heart disease could be included for the second season. And I will just express my opinion that as we move towards a respiratory viral prevention platform, I do think perhaps we should think about how we can harmonize across flu, COVID, and RSV some of the conditions, because I don't necessarily, there's like unusual circumstances like CSF leaks, for example, with pneumococcal vaccine. But other than that, I certainly am suggesting that this schedule actually highlights some of the minor differences, but they can be significant to patients. And I do think we need to start to harmonize some of the conditions as evidence allows and as is reasonable from an implementation standpoint for our providers, given the complexity of the schedule. Is there anything else specific to the schedule that would be useful for Dr. Wody and team to review? Okay. Dr. Wody, is there anything else?
Yeah, thanks everyone for your comment. I just wanted to comment on removing the asterisks, and just as a reminder that we added that because we wanted to encourage pregnant women who are on vaccine, providers to vaccinate pregnant women after the pregnancy for these vaccines that are contraindicated. So I think 2-3 years ago, we did not have the asterisks, and we felt that people would not think about vaccinating the pregnant woman after the pregnancy ends. So that was why we added it. That's the background.
Thank you, Dr. Wody. Dr. Paling?
I was wondering, do I need to make a motion to accept this schedule based on the conversation, based on the recommendations that have been added?
Yes, thank you, Dr. Paling.
I believe we were planning a combined vote, so we may want to wait on that motion until after the adult schedule is presented.
Thank you, Dr. Orton. Okay, let's please move ahead to Dr. Neil Murthy, who will speak about the 2024 updates to the adult schedule. And again, we really appreciate the work group's work on this. This is very detailed and complicated.
Thank you, Dr. Lee. Dr. Neil Murthy is not feeling well, so I'm going to present the updates to the adult schedule.
Okay, thank you.
All right, so most of the updates to the adult schedule are similar to the child and adolescent schedule. On this, so I'll go over the changes to the cover page tables, vaccination notes, appendix, and the addendum. So on the 2024 updates includes new and updated recommendations for the vaccine in red, for the vaccines list in red, and then for the others, we've made clarifying edits just like we did for the child. So on the cover page for how to use the schedule, we have a 5th step instructing providers to review the addendum, where we're going to list the recommendations that will occur after the schedule is published. In the table listing the names and abbreviations, we've added the pentavalent meningococcal vaccine, Mpox, and RSV vaccine. And here for RSV vaccine, we have the two brands listed as opposed to the child schedule. And then we've deleted the bivalent mRNA COVID-19 vaccine and Menacra from this table. Now, Table 1 lists the recommended vaccines by age. For COVID-19, we've changed the overlaying text to specify that the 2023-24 formula should be used. For RSV, we have age 19 to 49 years in purple, indicated that is recommended for some adults, not all adults, and we have the overlaying test, seasonal administration during pregnancy, to see notes. And then for 60 years and older, we have the blue bar indicating that this is a shared clinical decision-making recommendation. For the pneumococcal row, we have removed the overlaying text that said either use PCV 15 plus PPSV 23 or PCV 20, because the recommendations have been updated and it's a lot more nuances than what we had. And we've added Mpox, and all the ages are shaded in purple, indicating that if you have a risk factor, you should be vaccinated. Now, Table 2 lists the recommendations by medical indications, and it's similar to Table 3 in the child schedule. And we did the same thing. We wanted to align more closely to the instructions for how to use the schedule, so identify additional doses recommended based on the medical condition. And we also revised the color legends for this table and harmonized it with the child schedule. But here, for the yellow, we now have that it's recommended for all adults who lack documentation of vaccination or lack of evidence of past infection. Those are slight revisions from the 2023 wording. We just took the age and put it in the purple. So the purple now represents that it's not recommended for all adults, but it's recommended for some adults based on either their age or their risk for infection or severe outcome. Brown is new to the table, and we wanted to indicate that for some of these medical conditions, additional doses of vaccines would be needed. And this was to harmonize with the child schedule. And the gray, we now have no guidance or not applicable. And we've added the same header to Table 2 like we did for the Table 3 in the child schedule, just letting providers know that we use this table with Table 1 and the notes, and that there's some medical conditions that are not listed on the slide to see the notes section, and that individuals could have multiple medical conditions. And in the hepatitis B role for diabetes, we've indicated that for those aged 60 years and older, the recommendation is shared clinical decision-making. And for RSV, we have, for pregnancy, we have a yellow indicator that is recommended for all pregnant women, and the overlaying test seasonal administration. And for the other medical conditions, we used the blue because of the shared clinical decision-making in older adults. But now looking at this and based on the previous conversations, maybe it should be gray to change to gray. And then for Mpox, we have all the medical conditions in purple, because anyone with these medical conditions can have the sexual risk factors recommended for vaccination. For pregnancy, we've added C notes, and for men who have sex with men, C notes, and healthcare personnel C notes, because there's some more nuances to the recommendation. Now moving to the notes section. This year, we've added the additional information section to the adult schedule to harmonize with the child schedule. In the bullet for the National Injury Compensation Program, we've added RSV and would add MPOX, like previously noted for the CICP program. For COVID-19 vaccination has been extensively revised to align with the new recommendation. For routine vaccination, this is for persons who are not moderately or severely immunocompromised. And the special situation section lists the recommendations for people who are moderately or severely immunocompromised based on their previous COVID-19 vaccination history. And just like we did in the child schedule, we have some information that we think will be helpful for healthcare provider. The no preferential recommendations links to more information of the schedule and the EUA. The definition for what previously vaccinated means, and then some information for additional doses in those who are moderately or severely immunocompromised. Now, for hepatitis A, for routine vaccination, we wanted to clarify that people who are not fully vaccinated, they don't have a risk factor, but are requesting the vaccine can get the vaccine. So we revised that bullet to say any person who is not fully vaccinated and requests vaccination, identification of risk factors is not required, they can be vaccinated. And then for those who are at risk, we just changed the wording just to match what we have in the routine vaccination section. For hepatitis B, we added a new bullet that adults 60 years of age and older who request hepatitis B vaccine should receive the vaccine. And for those who are those living with diabetes and are 60 years and older, we've added a notation to say that this is shared clinical decision-making recommendation. We made for HPV vaccination, we made similar changes to the child schedule, which was to remove the bullet on the interrupted schedule, and then to clarify that if you've completed your HPV vaccination series with any of the HPV vaccines, you do not need additional doses. For influenza vaccination, we've taken out all the bullet for persons with a history of egg allergy, and we've added a note that they can now receive any influenza vaccine appropriate for their age and health status. And we have the link to the 2023-24 recommendation. We also had a bullet here for persons who had a history of Guillain-Barré syndrome within 6 weeks of influenza vaccine. We took that out because we already have that in the appendix. For meningococcal vaccination, we've added information for shared clinical decision-making, a resource. And we've also added the pentavalent meningococcal vaccine at the end, and we will also remove the preferred language from this section too. For MPOX vaccine, we've listed, we have a special situation section for those at risk, and we've listed what the risk factors are. We also have the same bullet for pregnancy like we had in the child. In addition to that, we have a bullet for healthcare personnel stating that except in rare circumstances, such as when no available personal protective equipment, healthcare personnel who do not have any of the sexual risk factors described above should not receive JYNNEOS. And we added this because there's been a few questions about if healthcare personnel providing clinical care for patients with MPOX should be vaccinated. The meningococcal section was extensively revised just to clarify, primarily to clarify the minimum intervals based on which product is used. And then for polio vaccination, based on the new recommendation, we now have a routine vaccination wording which says adults known or suspected to be unvaccinated or incompletely vaccinated should complete the series. And in the special situation section, we have for adults who are at increased risk of exposure to polio, who have completed the series may receive one lifetime booster. And we have included the definition of what a complete primary series is. And for RSV vaccination, the routine section addresses the recommendations for pregnant persons. We have that pregnant persons should be vaccinated at 32 through 36 weeks gestation from September through January in most of the United States. And we've also included the language based on timing, based on local RSV seasonality. We also thought it was important to refer to Nirsevimab in this section, so we have the language that either maternal RSV or infant immunization with Nirsevimab is recommended. And we refer to the child schedule for recommendations for Nirsevimab in infants. The special situation section here addresses the shared clinical decision making for those 60 years or older. We've listed the two vaccines brand that can be used here, and we've also provided some information for persons that are considered at increased risk for severe RSV disease. And then for the Tdap notes, we've clarified that a Tdap dose administered at 10 years may be counted as the adolescent dose recommended at 11 through 12 years. Now moving on to the appendix, which lists the contraindications and precautions. Similar to the child schedule, we've revised the header to include the links to the contraindications for Jynneos and COVID-19 vaccine, and we've updated the link to the for influenza vaccine to the current recommendation. We have incorporated COVID-19 vaccines into the table, and we have a different role for mRNA COVID-19 vaccines and then for the protein subunit vaccine. We've added RSV vaccine contraindications and precautions to the table. And in the and we've also added the pentavalent meningococcal vaccine to the table. And Mpox. And similar to the child schedule, we've deleted the bullet for severe allergic to latex from the HIP vaccine rule. And we've also deleted Menacra from the meningococcal vaccine rule. And lastly, to the addendum, which is currently blank, here's where we're going to list all the recommendations that will occur after the schedule is published. Thank you, and I'll now take questions.
Thank you. This presentation is open for questions. Dr. Long?
Yes, it's regarding Table 1, any of the slides around 79, 80 on my handout, 77, 78, any of them that have the colors.
Table 1? Sorry?
No, one that has a color. No, I think it's early. There you go. There you go.
This one?
Before that. The one before that. Table 1. Table 1. Thank you. Table 1.
Yeah.
The question is about the last phrase in the color definition at the bottom. So it's hard to read, but recommended vaccine, no, Table 1. You were there.
Oh, Table 1?
No, Table 1. You were there.
Here?
At the bottom thing. The orange is supposed to be recommended vaccination for adults who meet age requirement, fine. Lack documentation of vaccination, fine. Or lack evidence of past infection. Now, that doesn't apply to most of those. So I wonder why that's there. It certainly doesn't apply to pneumococcus, past infection with what? There are lots of them. I wonder am I misunderstanding something? And there's nothing in the notes that helps with that.
You're right that it doesn't apply to all the vaccines, but it applies to like measles
I can't
and
understand.
varicella. So it applies to some, and with that we've struggled with that a lot because it really
It applies to varicella, but it's the only one I can think it applies to, so why do I would put that under varicella rather than applying it to all oranges, because you don't say anything about it in the notes.
Camille Cotton, it applies to hepatitis A, hepatitis B, measles, others.
Measles,
We use it all the time in the adult world.
Lack evidence of past infection. So you do hepatitis B, surface antibody is positive, you don't give it, and you do that before you give it. Is that right?
Yes. Commonly. Yes.
Yeah, the general regs allows serologic evidence for past infections, and is consistent with some of the policy notes for some of the infections. I know measles, mumps, rubella, varicella, hepatitis A.
I might put that in the notes on a few of them that it applies to, but, I mean, coronavirus is a different thing. Influenza, it certainly doesn't pertain to. RSV, it won't pertain to. Tetanus, it clearly doesn't, because you don't make antibodies, so if you have evidence of past infection, you'd still give those. I mean, we could go down the line. We don't trust it for MMR.
I like it.
Why?
The way it is.
We're open to suggestion on how to handle this on both tables because it's very, it applies to some and not others. And
the internists like it.
Thank you. Why don't we go down the line and then Dr. Woody, if we could collect up some of these comments and if you could respond cumulatively, that'd be great. Let's go. Dr. Long, was there anything else you wanted to bring up?
No.
Okay, thank you. Dr. Cotton.
Thank you. Thank you. So for, can we go to slide 85, please? Table 2. And on RSV, where it's in blue, which is great for shared clinical decision-making, could we put 60 years of age and over, rather than C notes? C notes means click again. And anytime a clinician has to click again, it enhances burnout, frustration, and fatigue. The CDC had a very nice release yesterday about mental health in clinicians. And I would like to link that advocacy to the C notes. I do realize that we may be considering 50 to 59, so then there may need to be a change. But rather than C notes, I would just advocate for greater than or equal to 60 years of age with blue shared clinical decision-making.
That would be similar to the hepatitis B item on the hepatitis B row.
Yes. Yeah, copy and paste that. Yeah, I like that. Yeah, make it the same. In fact, when you start making things similar, it gets a lot easier. We like that. Me and the interns mentioned by Dr. Talbot.
Thank you. Any additional comments, Dr. Cotton?
No, thank you.
Thank you. Dr. Good.
Yes, hi, thank you. Just a couple comments on the very first page. It looks like for influenza vaccine, we have inactivated and recombinant, but there's not a cell cultured listed. As well as on the table.
Lisa, can you?
Hi, this is Lisa Grosskopf, the flu work lead. Essentially, for all intents and purposes, we regard the cell culture-based vaccine as one of the inactivated influenza vaccines. It is different in that it is cell culture-based as opposed to egg-based like the other ones are, but they're essentially interchangeable from a policy perspective. We do, in our recommendations in the R&R, sometimes call out CCIIB where we have to talk specifically about characteristics of that vaccine, but essentially it would not be treated any differently from a policy perspective.
Okay, great, thank you.
I hope that helps, thank you.
And then the other thing on table, the polio is listed everywhere but not in the table. And I don't know if that's by design because it's not necessarily a recommendation, but just an observation. And then the last thing is on the pneumococcal table 2. that we have maybe to have C notes. I know that burnout was just talked about, but since it is so complicated, maybe there should be C notes there for the pneumococcal vaccines. Thank you.
Thank you. Dr. Sineas.
Thank you. We can stay on table 2. I noticed that there isn't pentavalent meningitis on there, and it would be indicated for patients with asplenia who would need both Men-B and Men-ACWY potentially at the same visit if they're under age 25.
Thank you. Any additional observations? Okay. Dr. Williams?
Yes, I wanted to say that the LAIV on table 1 makes sense, where you have or between the IIV or IV core and the LAIV, but when you go to table 2, it gets very confusing to me. It looks like it's a separate vaccine in line 3. Looks like it's separate from the other 2 vaccines.
Sorry, I'm just looking at table 1.
Table 1 makes complete sense because you have the or there.
Okay.
And lines 2 and 3. And then going to that one, if you look at the LAIV4, I don't quite understand what the message is trying to be there, and the or has disappeared.
Okay.
Thank you. I'll keep going. Dr. Wody, please feel free to collect up these comments and then respond at the end. Dr. Paling.
I'll go after the commander.
Commander Grimes.
Oh, thank you. And Dr. Wody, appreciate you calling out on slide 82 that you would adjust the MPOX. Just want to also make a note on slide 67 on the cover for the adult schedule. There needs to be adjustment of the language around injury claims. And we're happy to help with that adjustment. Over.
Thank you. Dr. Paling?
I would like to reiterate my appreciation to the work group for the tremendous work that they have done. This is a lot of information that is really well described. And so I'd like to make a motion, if the time is good, to say that I'd like to move this forward with the recommendations that have been shared.
Thank you. Just hold for one moment. Dr. Wody, is there anything you'd like to respond to, or do you have any concerns about the comments and suggestions that have been given?
I have a few comments, and for the pentavalent vaccine not added to table 1 or 2, that's because it doesn't change the recommendation. So when we discussed this with the SMEs, we decided to put the information in the notes because the recommendation is the same for, it doesn't change it. And then for the comment on LAIV and IIV, we didn't quite, Lisa and I were looking, we didn't quite understand the comment. So in table 1, we have one role that for IIV4 or RIV, and then we have a separate role for LAIV. And then in table 2, we have the same thing, a different role for, one separate role for IIV4 or RIV4, and then a different role for LAIV.
Yes, my question was, it looks like they're 2 separate standalone vaccines, but you wouldn't get IIV and LAIV. In the other table, it had an or, IIV or LAIV. They're both flu vaccines. And then the other thing was that, this is Dr. Williams, and then the purple under 1 dose annually looks like it's applying to men who have sex with men. I was not aware of that as a indication for LAIV personally, and it just gets, I work with LAIV, so the indications there are confusing to me.
Okay. All right, go ahead, Lisa.
So the reason that men who have sex with men is called out for LAIV, I'm not sure. Actually, I can't read.
Yeah.
the slide now that I think of it.
Sorry. I can answer that. We wanted to, you will notice that for some of the, now that we have age in the purple, we wanted to call out that for that group, there's an age indication. So you can't use it for all men who have sex with men. They have to be between the ages of 19 and 49. And we did the same thing for the other. So if you look at the, had the orange where there's a precaution and also healthcare worker, we also have the 1 dose annually if you're aged 19 to 49 years. So we wanted to let people know that there's actually for LAIV, there's actually a maximum age for which you can use it.
Okay, thank you. And then maybe should there still be an or in between rows 2 and 3, since they wouldn't be getting both IIV and LAIV in a season?
Yes, we can add or, but now I understand what, to make it similar to the blue or with the, yeah, we can add.
Yes, thank you.
Okay, thank you. Anything else, Dr. Bodie?
No, thank you.
Thank you so much. So Dr. Paling, thank you for the motion on the table. Dr. Lair?
I'd like to second that motion.
Thank you. So it's been moved and seconded that we accept the updated adult and childhood immunization schedules, and we will vote on this after public comment. Thank you, everyone. For now, let's take a just a 5-minute break. Plan to reconvene at 10 minutes after the hour. Thank you very much.